Welcome to the final segment of our Insync and AIHE webinar series, where we tackle big issues in healthcare. Our collaboration is all about providing practical insights that can lead to real change. I have Dr. Prado and Dr. Chandrasiri here to share their perspectives. Let's begin. How do you protect yourself emotionally while delivering distressing news?
Well, it's a really good question, Shannon. And I think that it's quite complicated in the sense that we spoke about open disclosure having become a tick box compliance type exercise, which would convey that people are almost desensitized to it. So therefore, you could argue, is there an emotional impact from that? And if not, then is that a benefit? So that there is that balance, I think, between the emotional impact and desensitization to it. But at the end of the day, again, I think it comes back to how open disclosure is taught and the intention with which it's done. If you are genuinely and authentically demonstrating empathy and doing it for the right reasons, then absolutely there will be an emotional impact personally and potentially professionally as well. I think for myself, what I would try to do is put myself in the shoes of the patient's family and think, have I done everything I can possibly do in my power to either to openly disclose this and to put in place mechanisms to give assurances to the family that this won't happen again. If I was in their shoes, would I be satisfied with that? And I think when I reflect on that, and if I can genuinely say I've done everything I can, that does help in terms of that emotional response. And another point also with that is that it really goes to the type and nature of open disclosure training. At the moment, and this is a personal issue that I have with the current frameworks that actually recommend a low-level disclosure versus a high-level disclosure. So would we assume then you have a higher emotional impact with a high-level disclosure than a low-level disclosure? So this is why it's something that we do not encourage in terms of our open disclosure training. At the end of the day, open disclosure is genuine, authentic, and open. There are no levels to it. You can't say you're half sorry or you're fully sorry for something. So I think it's really important to really look at how we are teaching open disclosure and how we are setting up our frameworks that tells clinicians how to do open disclosure, because invariably that is going to have an impact on them emotionally after in terms of how they actually deliver it.
And just continuing that point, I think there's a few tools that both we teach in our courses, but also that I've used personally for some time now that I think is beneficial. And the first is that unfortunately, often this responsibility is left to clinicians or clinical executive like the medical director or chief nurse. And what happens is the other executive, including sometimes the CEO and often the board, are immune from this. And therefore, all the emotional burden is held by the individual, particularly at executive level or the director or the clinician. I'm a firm believer that just like every other aspect of running a healthcare operation, everyone understands the finances, everyone understands the activity, everyone understands the success of the organisation. Everyone should also understand what's happening when things go wrong. So I purposefully use the name of the patient throughout the conversation. I escalate these scenarios so that the executive are aware. This is something I practice and teach in terms of if you use the name of the patient, others are around and you can then share with your peers this emotional distress. Everyone should be impacted, not just you as the clinical people who are doing the open disclosure, but the chief finance officer, the HR person. They should know that in the hospital this occurred. We had to undertake this very complicated discussion, and they understand that because as peers, you share the other issues of your hospital. You share the financials. You share the workforce challenges. Well, you should share this as well. And similarly, in discussion with board directors, say the subcommittee of safety and quality, there's nothing more powerful than using name. And by using the name, others can share with you that emotional response, so you're not feeling isolated. The second is part of the way I've dealt this myself is to remember these cases that are significant and have them as case studies that help me commit to that improvement ongoingly. I remember the names of these patients 10 years later, and my commitment as a medical director about what we're going to do and change. And when I come to a new organisation, I come to a hospital, look and see, are those things there? Because that's the way I mitigate my emotional distress with it, is by commitment to improvement constantly. You ask permission from the families, they always say yes, use this as a case study. Use the case study at councils of safety and quality in your hospitals. Use them when you're teaching your colleagues at the hospital level, and use them to observe and assess the performance of clinical governance. Because by doing so, I find that alleviates and mitigates my emotional part, because my commitment to the improvement is part of my mitigation. Because if you just sit on this and you see nothing change, or you don't develop a program of improvement, that actually is very difficult. Finally, I'd say that one should always, in these roles, just have either good peer contact or mentors. If you're more junior in your career, a mentor is excellent for someone you can actually discuss this with. If you're a position that you more likely have a peers, then your peers should be those at executive or those working in other organisations, and use that as an opportunity to assess how would they have done things differently, if at all, how were you doing it, how you're feeling. Trusted peers in this regard are very useful. In our book, that's Practice of Clinical Governance, we use case studies. In our teaching, we use case studies, very much so people can go, that's what this is about. This is how incident management's done. This is what open disclosure about. True life case studies which show the complexity, so that you can then deal with as well, okay, what does this mean for the clinicians involved, the organisation, the people involved, yourself involved. So you include that as part of your overall management, more importantly, of your overall professional development.
Thank you, Dr. Prado. And that wraps up our webinar series. So thank you to Dr. Chandrasiri and Dr. Prado from AIHE for their valuable insights. And just before we log off, are there any final thoughts that you'd like to share with the audience?
I think just to re-emphasize the cultural shift that is needed in a lot of healthcare organisations in Australia about how we perceive open disclosure, how we perceive clinical incident management, and to be aware that the courses and training that has been out there for years and still out there may not be fit for purpose in the current world and with the current challenges that we're facing. And that perhaps even though we think we know how to do it, or we think we know we've been taught how to do it, to perhaps just take a second look to really understand, well, am I doing this in a contemporary, practical and relevant way that is fit for purpose and is of ultimate benefit to the patient? I think all of these healthcare training courses and programs should ultimately have the fundamental thread that everything is patient-centered, that everything is for the benefit and the delivery of healthcare to the patient. It is not so much about us meeting compliance requirements and regulations. And I think that's a fundamental shift that we've got to change in our thinking, right from board leadership down to executive leadership, and then director and manager level down to the clinicians as well, which is why we are very excited about this new partnership between AIHE and Insync, because we want to be providing more contemporary open disclosure training and understanding the experiences of patients and staff and tailoring our training in order to address those issues that we are constantly seeing over and over again.